Hello and welcome to Dental Health Matters, brought to you by the BSDHT. Today's episode focuses on recognising the signs, early detection and having confident, compassionate conversations with patients about mouth cancer. I'm Rhiannon Jones, President of the BSDHT, and I'm joined by Jocelyn Hardin, Dental Hygienist and representative of the Mouth Cancer Foundation, alongside Professor Mike Lewis, Emeritus Professor of Oral Medicine at Cardiff University and Clinical Ambassador for the Mouth Cancer Foundation. Together we'll explore the vital role dental hygienists and dental therapists play in identifying early changes, knowing when to act, and communicating sensitively around risk factors such as smoking, alcohol and HPV. We'll also look at practical red flags, referral pathways, and how routine screening really can save lives. So today's theme is recognising the signs, early detection and confident patient conversations. So today we're joined by Joss Hardin and Professor Mike Lewis to explore the vital role dental hygienists and dental therapists play in the early detection and prevention of mouth cancer. We'll revisit key signs and symptoms to look out for, consider how best to act when something seems concerning, and also talk about the approach we might take with patients when it's a bit more sensitive, and to have those important conversations around risk factors. So Joss and Mike, thank you very much for joining us. So as a starting point then, could you both share a little bit about your work with the Mouth Cancer Foundation and what motivates your commitment to early detection and patient advocacy? If I could come to you first, Joss.
Well, thank you very much. Thank you for inviting us. So I'm President-elect. I became a clinical ambassador and was invited to be part of the charity in 2018 when I met with Christian Joshi at a dental show. But up till then, I'd had quite a few head and neck cancer patients coming to surgery, coming to my clinic in general practice, and I didn't really have any education. I look back through my books that I qualified with. I had nothing to help me and support me looking after these patients. I had my skills as a dental hygienist, but that's not enough for these patients. So it's been a real journey of learning. So in 2018, I became part of the charity and got to know a lot more patients and families and caregivers and things like that. And it really drives your passion to make things better and to improve things. So before, during and after their journey is vital for all of us to be part of, but we need to improve that education. So yeah, it's been great to be part of the charity and to meet Prof. Mike Lewis on this journey too. So yeah.
No, thank you, Joy. It's been an absolute delight to have been invited. I'm a latecomer to the game, but I've recently been appointed as a clinical ambassador for the foundation. I've spent the last 40 odd years of my clinical life working with mouth cancer, sadly seeing the increasing incidence over that period of time. I had retired from my Professor of Oral Medicine post in Cardiff University, but I'm back now doing 2 days a week clinical work, essentially addressing the urgent suspected cancer referrals, which sadly, again, the numbers are going up. So I'm still dealing with the patients with mouth cancer, but I'm trying to contribute more now to the Mouth Cancer Foundation in ways I think I can help. And one of them is doing something like this.
Yeah, great.
Thank you. Well, they're very lucky to have you both. So thinking about early detection and how it actually does save lives, why is early detection so critical in mouth cancer, and what makes people like us, the dental hygienists and dental therapists, particularly well placed to identify these early changes?
So it's about having the confidence to talk to patients about mouth cancer in every appointment, which people are or not comfortable with. It's about encouraging self-screening, but it isn't just about that patient that you're giving that information to and advice to. They're going to pass that on to anybody in their family, their work colleagues, somebody down the pub who mentions they've had an ulcer for a while. So it's about actually educating our patients and taking every opportunity. Would you agree with that, Mike?
Oh, yeah, absolutely. It's sad that if we ask people about what sort of cancers can you get, they'll say breast, they'll say colon cancer, they'll say pancreas, but very, very often they don't think mouth cancer. But increasingly, I think there is a growing awareness due to the activity that we've been doing over the past few years. The early detection, from my point of view, is that the smaller, the better. it's absolutely critical that the tumour is detected when it's 2 centimetres in diameter and hasn't spread to the lymph nodes in the neck. Unfortunately, our mouth cancer spreads quite quickly to the neck. But the single most important thing in the time of detection is detection 2 centimetre diameter and less, and not spread to the lymph nodes in the neck, because that really impacts on the patient's outcome.
Okay, it's interesting when we think about how things are changing, not to make this political, but how things are changing, that we may see people less often. Some people can't come, won't come, don't come, but actually these regular appointments isn't just about teeth and mouth care, is it? It's about these detecting things as well. Thank you. So, I mean, we often talk about red flag symptoms. What are the key clinical indicators that every hygienist and every therapist should be routinely aware of during their examinations?
So there's a number of signs and flags that we should be looking at. We should initially be listening to what the patient's telling us. If they've had that sore throat for a while, that lump for a bit, that is what we should be listening to, but also what we're checking for intraorally as well and extraorally. So there are many other signs and symptoms, which the charity has on the website. But be aware of them all, get to know your anatomy really well, and just something that doesn't look right. And then check with a colleague in the practice, get them to have a look as well, review in 2 to 3 weeks' time. We all work as a team, so we should do the team thing where we all check for things, and there are more signs.
Yeah, well, I, as you may know, I did a study a few years ago I published, which demonstrated we did a study on visual detection of mouth cancer.
I remember taking part in that.
And yes, and I'm pleased to say that the dental hygienists and dental therapists came out as the top dental professionals who could detect the mucosal abnormalities, which is great, because the dental hygienist and therapist, you're spending time looking at the soft tissues, and you'll notice an abnormality. You know what's normal, but more importantly, you know what's abnormal. And so, as Josh said, there are criteria for the urgent suspected cancer referral, which I mentioned earlier, such as the ulcer that hasn't healed up in 3 weeks, the lump that's been persistent and unexplained in the lip, the red and white patches. We used to get all worried about white patches. I used to do a white patch clinic. But in fact, now it's a red and white patch clinic. These are the worrying signs. The first detection system is your eyes. So you will see something and think, ooh, that looks a bit abnormal. The next detection system is your fingers. Mm-hmm. So if you see something that looks abnormal, have a feel of it. Because usually, as a rule of thumb, something soft is usually inflammatory. Something hard is usually neoplastic. Mm-hmm. So it's not just see it, but see it and feel it.
A lot of people tend to do intraoral examinations just by using a mirror and retracting. And that's not good enough in my eyes. People need to get their fingers and thumbs in there.
I think that you'll see the abnormality, but then with the gloves on, have a little feel.
Yeah.
Because people will worry about an unnecessary referral. Actually, if you can wipe it off, that red and white mark that isn't actually a red and white mark, it wiped off. Yeah, that I guess.
And review to 2-3 weeks' time.
With the team as well, yeah.
And so sometimes it's often asked when the patients come in, have you had any changes in your mouth? Are you worried about any lumps or ulcers in your mouth? You ask that question. But also sometimes they'll say, yes, I'm really worried about these lumps on my tongue. And then you can reassure them, no, they're the circumvallate papillae. Mm-hmm. They're supposed to be there. Yeah. What about these lumps in my lower lip? No, they're your minor salivary glands. They're supposed to be there. Mm-hmm. So you can reassure them. And the dental hygienists and therapists are adequately trained, really well trained to be able to do that. And it reassures the patient.
Absolutely. Do you think there's a place, I remember we did it with the undergraduates, where we offer the patient a mirror so they can watch us do the examination, so they understand a self-examination a little more.
Get them used to their own anatomy. So
what is normal.
I use that a lot. I mean, I think if the patient is worried about something, I get the hand mirror out and say, look, is this what you're worried about? Yes. So we all know that we're talking about the same thing.
Okay, and then thinking from a clinical referral system, clinical photographs useful to you?
Essential.
Essential, because that's something I don't...
Absolutely essential. There are some referral systems now, the dermatologists, if you're referring in for skin, they won't take your referral unless there's a photograph. When I get a USC referral, before I even read it, the first thing is there a photo? And if there's a photo, I can say yes or no. A lot of the time I can say, no, that's geographic tongue. Okay. That's a polyp. And photograph, absolutely essential.
And then that in turn frees up the appointments for people who absolutely need it. Yeah. Thank you. Definitely. That's really good. And there are courses people can do on clinical photography as well, of course.
Yeah.
Okay, so thinking about something that we've seen in clinic that we just doesn't sit right. It is a red flag to us. We know that patient. We know what's normal. This doesn't look normal. If we notice something unusual, what would be the recommended next step with regards to examination, record keeping, and I suppose reassurance as well as referral?
Yeah, so what I've done in the past with a couple of patients recently is taken a photograph, had a good look, measured it, seen, asked how long it's been there, is it tender, what colour it is, give as much information as possible from that. Get a colleague to come in. I mean, one time I had no other clinicians in the department, so I had to send the referral myself. I knew it wasn't right, really not right. But generally I would get a clinician to come in and have a look-see, and then just know the protocol. I would say have that protocol in place before you need to use it. Because the moment you need to use it, your tummy's turning. And, you want to do it right and you want to send it, quite quickly. So I would then ask the clinician, what do you think?
Yep.
And,
Well, I think you're absolutely right. Record it in the notes. Please do not use the word lesion. I've been running a campaign for 4 or 5 years for the abolishment of the word lesion.
Okay.
Because if I get a referral, dear Professor Lewis, can you please see this patient with a lesion on the tongue? It's meaningless to me. The word lesion comes from the Latin lesionum, and it means injury. So they've got an injury on the tongue. No, please could I see this patient with a red swelling on the side of the tongue or an indurated ulcer on the side of the tongue? Not using the word lesion, using clinical descriptive terms in the referral helps me in secondary care, but it's also far better practice in primary care, because you're actually recording what you're seeing. It's an ulcer, it's a white patch, it's a red and white patch.
So when we talk to our patients about this, so maybe we say to them, it's likely to be nothing. However, I'm going to call a colleague in, we're going to write the notes about it. In 2 weeks, if it's still there, we're going to refer you. So we're doing the reassurance, the referrals. But we probably already know that patient's high risk of something. So conversations about things like alcohol, tobacco use, and HPV, human papillomavirus, they can be difficult for us. What practical approaches do you think could help clinicians in these situations so that we can talk to patients in a more supportive and non-judgmental way?
So for me, with all my patients, I always go through the medical history. What medications are you taking? Okay, are you taking this, and this? More often than not, they're taking that list, but sometimes there's changes, so we're used to that.
Particularly important with immunosuppressive drugs. The immunosuppressive drugs, people like renal transplant patients are well known to have a higher incidence. So the medical history, if there's drugs there, I've got a couple of patients who've had serial carcinomas in the mouth who are immunosuppressed because of their renal transplantation. So that's why it's important from the medical history. So good point.
Don't just say, has anything changed? Because they will always go, no. So we have to go through that, and it takes time, and you have to take that time. So go through the medications and then ask if they're drinking alcohol, how many units roughly you're drinking. They'll either ask what a unit is, and you'll say, and then they'll either say yes, thereabouts. So you write down what they say, and they may or may not want to tell you, but that's fine. And then if they're smokers, then you ask them, do they need any help? Always be aware to signpost them. And then you'll say to them, I'm going to perform an intraoral and extraoral examination. Are you aware of the 3 risks of head and neck cancer? One's smoking, you're not, or you are. One's drinking alcohol, you are, you're not. And if you're doing both, the risk is raised by 30 times. They go, ooh. And then you say, and the other risk is HPV. Have you heard of HPV, human papillomavirus? They'll either say yes because they're mum of a daughter who might be sort of 35 and younger, so they're aware of the girls being vaccinated. And also, are you aware that the boys are vaccinated now since 2019? It was 3 vaccinations, went to 2 vaccinations, now it's 1 vaccination. They go, oh, that's interesting. And I say to them, so there's human papillomavirus, 200 viruses, most of them are warts and bruchers and things. There's 2 particularly that are sexually transmitted, and they go, oh, crikey, I only came in to get my teeth cleaned. We're talking about a lot of stuff here, and I'm going, I love to educate my patients. I take it as a great opportunity to educate you. Is that okay? And they go, yes, Joss.
They would never say no to you, Joss.
And then I say, so the 3 main risks, head and neck cancer, smoke, And then I say the boys and girls are vaccinated because it lowers the risk not just for cervical cancer, it's for head and neck cancer, penile cancer, anal cancer. And they go, oh, wow. That's really important. I say, well, it's lowered the risk for cervical cancer by 87% so far. And they go, gosh. So immediately
the first time I heard that, the first time I read that from the American study about cervical cancer in women, I almost fell off my chair.
in such a
Because you say
short time.
it was 90%, 87, 90% in a 10-year period. That's mind-blowing.
Yeah.
So, yeah.
So immediately they see you as a healthcare professional. We're not just about teeth.
So for teams working in areas with higher deprivation and possibly known risk factors then, how might screening and those conversations that we have with these patients need to be adapted?
So if you look at the recent atlas that Prof. Marshman did about the risk areas of England, you can look at the different areas of England and how they become darker. You don't even need to know the numbers. You can see the numbers are getting darker and the areas are getting darker of the atlas. So those clinicians in those areas need to really have those conversations with their patients, and they will know those patients that are higher risk, but don't just assume, give everybody the same message, and to be vigilant and to know that the charity is there for you. And if you haven't got time or, you're concentrating on something else that the patients come in with, then go to the charity. The charity is there for help and support. Would you agree?
Oh, absolutely. Yeah. And I think, but the message is mouth cancer, anyone, any age. And I've been talking, as you may have come to some of the talks, and the youngest patient we had was a 16-year-old boy who came through the unit in Cardiff. 2 months ago, 10-year-old. A 10-year-old has had to have a hemimaxillectomy, and she's got an obturator. Now she's too young for implant. But a 10-year-old child came in with a palatal ulcer that was a squamous cell carcinoma.
Good Lord.
Right. Okay. That's very rare. Okay. The vast majority of the patients that we diagnose on the clinic that I diagnose have tobacco, smoking, and drinking habits, and those are the factors. But in certain individuals, there are other factors. So always remember, don't discount it because you think, it can't be, it's a child. So I've had my eyes opened even wider recently. When I used to say 16-year-old, we've had a 10-year-old now. So I think it's everyone. Obviously, in areas where there's higher incidence of the risk factor usage, then you're raised a little bit. I'll have a little closer look, but should really do the same. Everyone gets the same examination. You treat everyone the same because you just never know what's around the corner.
And also, you've just made me think now, we work in teams, which is lovely, but there is sometimes an assumption, particularly if you're a dental hygienist or a dental therapist working under a prescription and a treatment plan or care plan, that actually someone else has already done this mouth cancer check. And it may even say in the notes that they have, but actually when you talk to the team, you find that they don't do it the way you do it. They're maybe not up to date with facts and figures and what they're looking through. They might not think to do it on children, for example. So it's a really important conversation to have with your team, isn't it?
I would always say have somebody who's a champion in the team.
Yeah.
There's always somebody who wants to be a champion of different things in the team, and maybe one of your team wants to be that champion for mouth cancer, and maybe do an audit of the notes, but then to have conversations and then have team meetings and just to update everybody. Come back from dental shows where they can hear lovely prof speaking or myself, or but there's always golden nuggets there from every presentation to go back with, and then share that with your team. Share the knowledge.
What a valuable type of team meeting to have as well, isn't it, than just agenda points.
Yeah.
I think it just crossed my mind there as well. A good point to remember is that even that somebody else might have done it. Mouth cancer, as well as being sneaky from our point of view in spreading to the lymph nodes in the neck quite early, unlike skin cancer, it also grows at different rates. Now, not all mouth cancers grow at the same tumour velocity, as it's referred to. And we have examples where patients have had some very slow-growing tumours and detected after 18 months or so. But we've also had patients who have been on long-term review for certain conditions, and suddenly it just blows up in front of you. One particular case was a gentleman with lichen planus on his tongue, and he came back early because he said something's gone wrong, and he was right, something had gone wrong, that it had blown up. So tumours in certain people can spring up and they can develop very rapidly.
Okay, so even if that person's had an examination a month ago, you would still want to do that check.
Yeah.
Great, thank you. There's so much to think about, isn't there, after this? But I'm thinking now, I'm hoping that the listeners, the viewers are thinking, okay, I think I need a bit more training. Or we've heard about the website. What's out there from the Mouth Cancer Foundation particularly? What's out there that can help them deepen their confidence, or improve their skills, as it were, for these people listening now? I think, right, I need to up my game.
So the Mouth Cancer Foundation has plenty of downloads. There's lots of printable leaflets and things like that they can have. There's also videos on there. There's lots of ways that they can update their training. They can go to dental shows. They can listen to speakers. It's just ask them lots of questions. Ask lots of questions. And if you're not confident, please ask. There's always a clinical ambassador that will help. They will come back to you with an answer if you contact the charity. So please feel free. We are there. Might take a few days, but we are there. So please feel free to contact the charity.
Yeah, because you've got the chat site. Because I've just joined that as well now to be able to see if I can help with questions that are coming in. So
there's a Facebook group for patients. There's lots of caregivers on there from all over the world. There's quite a number on there now, which is run by Karen Leishing-Schroeder.
I think that's another good point with the foundation. You've actually have sufferers, people who've been through that journey, and I think that's great when people can say, well, they can ask questions of people who've been there. They've had the mouth cancer, they've had the treatment, and it's always so good from people of personal experience.
Yeah, it's really important for the charity to have patient ambassadors. We're very lucky to have the patient ambassadors we have. They give their time freely. They want to educate dental professionals. They want to help us understand exactly what that journey feels like. Yeah. It's very different to reading it in black and white in a book.
Lived experience.
So, we're very grateful to the ambassadors there. So,
And we're very grateful to you. And I know you're very modest, but you and I have had a similar journey in that we've ended up in head and neck departments. It's different, obviously, but there's no rule book. You haven't taken over from someone. Could you tell us a little bit about the little project that you started that ended up being a huge project?
Oh, yeah. Oh, my goodness.
Ended up being a book.
I know.
Tell us about that, Joss.
So in lockdown in 2020, I started in January 2020 in the Max Fax department. I had this time with patients who were really struggling during lockdown. They were either just diagnosed, going through their journey, or just finished their treatment. Patients I'd never met before with major facial deformities that I'd never seen before. So as a group, I thought, gosh, this isn't very good for people coming into this area of care. So maybe we should start a leaflet, a little thing. So there was 15 of us in the group. So we decided to take a topic, go and find a professional that runs that particular area of expertise. So yeah, great, okay. But then that project kind of got legs. And so I was so what else should we have in this? So then I contacted my lovely mentor, Dr. Eva Ross-Vodoska. She was like, I'm going to put you in touch with Dr. Janine Brooks. And she was like, I'm going to put you in touch with Wiley. Are you happy with that? I was like, yeah, sure. It's lockdown. Okay. So off that topic went, and it grew from 15 subjects to 49 chapters with 56 contributors, of which one is the lovely prof here.
Delighted to help.
Which is amazing. There's a lot of people in that book I've never met. I said, hi, you don't know me. Do you mind writing a chapter for like 2,500 words with your own images too? I know you're really busy at this time, but do you fancy? So people said yes. Many people said yes, kindly.
It was a great thing to do.
Oh, amazing.
And the funds from the sale of the book go straight back into the charity as well, don't they? Which is that's a lovely thing to do.
What shocked me was that we don't have a problem just with this education in the UK. It's international. So the book has been sold worldwide, which blows my mind when I see it's been sold in China and Australia and things. It's just incredible because it goes from the general practitioner's point of view into all the different things that you can see.
All the specialties are there. It's great.
All the different.
And I remember reading one of the very first reviews that came in, and it was saying, why is this not for everyone in dentistry? Although the title suggests it's for dental hygienists and therapists, because where your idea came from, I think everybody should have a copy. All the
reviewers have said, definitely.
So wherever you get your books from, you can get a copy of it.
Thank you.
If there's any people working in specialist solutions like you, there is a yearly course run by the restorative dentists in Swansea at the present time, where it's for restorative dentists who are doing the reconstructions, the implants, etc., etc. But they do, and increasingly, I've been lecturing on it, there's increasingly dental nurses, dental hygienists, and dental therapists who can go on that 3-day course, and it's very good, it's very hands-on. And so if you are working in one of these units, there is a course. It's held once a year, usually in September, I think, in Swansea.
So let's put a scenario to you now. So I was clinical this morning. I've seen a patient. I've known them for a long time. I know something looks different. I've examined them. I've explained it to them. I called a colleague in. We both agreed that this looks different. I'd like you to talk me through the referral process now and actually how that can differ sometimes and how it's not always quite as smooth as we might like it to be. If I can come to you first, Joss.
So from my own personal experience, we haven't had a problem with referring. We've worked with the colleague and then the electronic referral form has been sent off. However, I know on different occasions with different presentations around the country, colleagues have come to me to say, I have referred and it's been bounced back because I'm a dental hygienist, I'm a dental therapist, and they won't accept it, which kind of gets my hackles up a little bit because that's not the way it should be done. And as the research shows, we are just as good, if not better, than other clinicians. So they should be accepting those referrals and not just looking at us as being dental hygienists, dental therapists. It's a clinician that's referred it to the department. But what are your thoughts?
Yeah, absolutely. I think where their electronic systems are in place, such as Wales, it works very well. I personally will take a referral from anybody if it's a dental hygienist, dental therapist, somebody that is worried that the patient may have a mouth cancer. I'll see that patient. But there are big, as Joss rightly says, there are big variations within England. I'm not too sure about Scotland. Scotland usually have themselves in good order, and I'm not too sure about Northern Ireland. But I think if you're worried, you've got that patient, then try and if you have to get a clinician or the dentist in the practice or somebody to refer or put their signature on it, please do it. We all know cases where patients have been bounced around from the dentist to the doctor, to the doctor, to the dentist, without being referred, which is terrible. I was speaking at the Mouth Cancer Foundation walk. There's a group called Young Tongues.
Yes.
And because we were walking along doing the charity walk, 10K walk, another one next September.
Absolutely.
Anyway, I was chatting to this lady. She was quite young, and I thought, my goodness. And she had her survivor banner on. And I said, what was your story? And she was delayed by about 4 months being bounced between the doctor, the dentist, and nobody referring it. But which shouldn't happen. It shouldn't. It's just, we've got to sort that out.
No, and they live the effects of that late diagnosis and late treatment for the rest of their lives. Yeah.
And if you listen to Roy Anthony's story, dental hygienist, he had to refer himself. He wrote that referral, he signed that himself. So it should not be like that. We should all be singing from the same song sheet. Yes, we don't want to bung up the system. We need to be able to, triage well in the department, which I think happens very well. But we need to be not bounced back. We do look and we can see things.
Absolutely. So I guess for somebody who has that bounce back, they can deal with it initially, but also to come to the Mouth Cancer Foundation, raise it as an issue in their area so you can be an advocate.
Yeah.
But also the British Society for Dental Hygiene and Therapy, if you write to them and to the inquiry's email address, so that we can bring it up with the Office of the Chief Dental Officers and the sort of local side of things as well to raise it as an issue. Because I know they are aware of it and they are trying to...
I think the pathways are changing.
Yes, they are, absolutely.
They are changing shortly.
But sometimes it just adds more weight when it comes from a big organisation as well.
Yeah,
so.
100%.
Oh, thank you for that. That's great.
Brilliant.
Okay. Thank you very much to Joss and Mike for sharing your insight and your guidance and just having that conversation, because actually it gives us all confidence when we know what we should be doing and how we can do it. And I guess to our listeners as well, this could save people's lives. This is a really, really important thing to do. So if anything has sparked your interest today, you now know where you can go for resources, particularly visiting the Mouth Cancer Foundation website, but also the BSDHT, our society's member hub as well, and you can find links that way. And I always think whenever we go to any training, they always ask about suggested speakers and topics. This is a really important thing. We think clinical is in perio and restorative and such, but actually this is an incredibly important topic.
Yeah.
So thank you very much.
Thank
from
you.
the BSDHT.
Thank you very much.
Thank you, Rhiannon.
Thank
Pleasure.
you.
It's always good working with you.
Yeah, I agree.
Thank you very much.
This episode of Dental Health Matters is supported by Oral-B. Oral-B is committed to making oral care more inclusive and accessible for everyone, and share our commitment to advancing education and promoting better oral health. We're grateful for their partnership in making this podcast possible. Hi, Michaela. Thank you so much for coming and joining our podcast, Dental Health Matters. So you are a previous president of the British Society for Dental Hygiene and Therapy, but you're here in your role with P&G today. So tell us a little bit more about your role and your title.
Okay, it is quite a mouthful, isn't it? I am the scientific and professional scientific relations manager for the UK and Ireland. So really my job is about looking after the influencers in the dental profession. So I work with the likes of yourself, Rhiannon, and many other associations, professional bodies, and many other speakers to teach them the science, the relative science, and to work with them in order to share our message. So to be quite fair, it's not dissimilar from the role of president of ADHD. You kind of get your fingers in many different pies, and definitely something that I wouldn't have been able to do without having done that role first.
Oh, that's good, a good grounding for it. So, well, I'm really glad you can be here today, but I want to explore some of the products. I think a lot of people will be very familiar with the brand and the products, but I'm wondering, is there anything new that we can see in 2026 and expect from you?
Well, we have just started our launch for the kids IO brush, which I think you probably will have seen the advertising definitely on television by now. And we've got a whole range of different types of educational resources that are available for our profession to be able to use in order to talk about looking after kids' teeth. And obviously this is branded with Disney's Lilo and Stitch, and it's brilliant for the market, but also it's got our technology, which is fantastic, and the amount of science and research behind using power brushes over using manual brush is obviously quite heavy. So it makes sense then to make sure that we start these habits early in life. And so that's why we're launching this brush.
That's great, and it's a huge investment in the next generation as well, isn't it?
Oh, absolutely. I mean, there's quite a lot of different research studies, as you know, but one in particular shows that those who actually have problems with their baby teeth will end up with caries much more likely in their adult teeth. So those habits need to start early. They need to start really early. And I know that we tend to talk about, I'm talking about as a clinician now, not as P&G, but we would tend to try to get them to brush with a manual brush first. But all the research that we're looking at now is swaying against that. There's no real benefit just from using a manual. And so this kids brush has been launched, as I said, at a really good entry-level market price, which hopefully makes it accessible to everybody.
Yeah, it's important for families, isn't it, with the increasing cost of living?
Absolutely, absolutely.
Oh, that's great. Well, I look forward to seeing more of that. My children are a tiny bit past children's toothbrushes, so I think
Lilo and Stitch might be just a little bit too young for them at the minute.
So I'm thinking that's supporting the public, but also you support the profession, you support our organisation brilliantly, and we really value that partnership that we have with you. But I'm thinking about what other ways can you support the profession through education and backing the research?
Well, there's so many different things that we do with the profession, and as I said, that's mainly my job. We work with Test Drive. Obviously, Test Drive is a big educational tool, and yourselves, you have actually educationally endorsed and accredited our Test Drive program, which is a way for people to be able to demonstrate how to use an electric toothbrush in the mouth, which, as you know, is 70% more likely to actually change behaviours, which is great too. So, and it's a free resource that we give to all practices, and obviously the heads then can go home with the patient as well. So we're trying to reduce any kind of wastage that we can use here. So that is one way. Another way we look at is the Oral-B professional website. On that we have a plethora of different resources now, not just educational resources for our members, and with the webinars that we do. Myself and my colleague work very hard at getting some big names onto our webinar field, and we do a programme which runs along the academic year, so from September to June, and it's all free, so well worth having a look at that. But we also have different things like we have the Atlas, which is a guide that you can use in surgery for showing patients about disease. We support many different programs that are ongoing throughout the world. But in particular, Ariane, you remember our program about disability champions as well, where we could get people to sign up and get educated to show that their practice is open to helping people with disabilities, and that they were trained and ready to welcome them. Yeah, First Smiles is the other one that we do, don't we?
Yes.
Which I think is really beneficial for the public.
Yeah.
As a joint venture, obviously, we both work at this together, BSDHT and Oral-B. But you do so many resources for that. That's a great program for us to be working with, and we reach nearly 5,000 children every year.
Yeah.
I think it's fantastic that we do that together. So there's loads of things that we do to help the profession. There's lots of things we do to help the community.
So I'm thinking, as the year now, 2026, where can listeners and viewers see you? Where will you be in 2026?
Oh gosh, that's a really good question. Obviously, we will be with yourselves at the Oral Health Conference in Wales this year, isn't it?
Yes, it is.
You'll be standing down as president, so we'll be there for that. And I'm sure there'll be other big venues, but as I focus mostly on the hygiene and therapy market for the UK, that's my big event of the year. So definitely be seeing you there. We may be at some of the other shows as well, some of the smaller ones.
Well,
too.
you support us all year round anyway. We'll be running First Smiles again in the summer, which
Fantastic.
is wonderful. Yes, the conference this year will be in ICC Wales on the 27th and 28th of November, so save that date. But these partnerships mean a lot to us as a company, and I'm not always certain that people understand how important it is that we can't serve our patients well without the support we get from you, and you can't support us without the feedback
absolutely.
you get as well. So
it's a win-win situation, I think, for both of us, is that we get to do good and help spread the message to increase the oral health of the nation, really, which is what we're both about. And
absolutely.
And it's good if you've got a common goal like that. It makes it easier to work together to get that. Yep.
Yes, because there is always a monetization side. It is a business after all, and I take money from my wages. I get paid to do what I do, but ultimately, what I am selling to people is health. But I need the tools to do that as well, so it's accepting that. Great. Well, I look forward to that collaboration. This is the part of the interview where I like to be a little bit more provocative maybe and ask you maybe the more awkward question, as in...
Far away.
Yeah, well, some people don't want to ask, do they? But they're thinking it, and it's important. And I would say I work in an NHS hospital where some of our patients, they can't even raise the money for the bus fare to bring their child to an appointment. So I'm thinking, okay, the extreme. I would love for them to have a child's toothbrush, for example, or for the adults to be using one of your electric toothbrushes, powered toothbrushes, but sometimes they seem very expensive, and I think maybe it's a misconception, but they perceive them to be too expensive and out of their range. What do you do as a company to consider that?
So what we tend to do as a company is that we have different ranges of brushes that we use, and we go from the top of the range right down to, we've just had an entry-level brush in the IO2 that's been introduced, which is an awful lot more accessible financially. And we also work with coupons as well for dental surgeries, where we can provide dentists and hygienists with a QR code where they will get the best price, which will come from one of our shops, but mostly really what we want to do is try to promote better health. So we do everything in our power to be able to give that to the right market at the right time. We have other electric brushes further outside that IO range as well that we can use and that are quite reasonable to be used.
Okay, no, I think that's really important to know. Maybe people don't understand the range, and the coupons that you were saying about, that's great. So my local representative would always come in, check that I have what I need for my test drive. I think when you can give the patient the head to go home with and the coupon and explain the differences on the back there, and that they see that there's a range, that's really valuable to them as well. So, good. I speak on behalf of our society just to thank you for the support that you give us year on year on year, and also thank you for coming today, sharing that with us.
Welcome. Pleasure. Thank you.
We'd like to thank Oral-B, the market leader for electric toothbrushes, for their support of this episode. By partnering with BSDHT, they help us amplify the voices of dental hygienists and dental therapists and keep prevention and education at the heart of our profession.
Hello, it's Simone Rosario here, President-elect for BSDHT. This episode, member question has asked, I'm a dental therapist and I've recently joined a new practice, and my employer has loads of Invisalign patients and has asked me to place composite attachments for Invisalign. They wanted to confirm from an authentic source before they say anything. Thank you for coming to BSDHT for this inquiry. Our response to this inquiry: as much as dental therapists can provide composite restorations in line with our scope, it is beyond our scope to provide treatment that will involve the movement of teeth. And by providing composite attachments for Invisalign, this would be deemed beyond our scope of practice. We can, of course, remove attachments as long as adequate training and understanding is applied. However, when it comes to placing attachments, it would be considered beyond our scope. I would encourage the colleague to consider the worst case scenario if it was to occur. Was the care that they provided defendable? And was it within their scope of practice? And as another layer of cover, I suggested that the colleague contacted their indemnity provider because, again, if anything was to happen, they would be their first point of contact for support and guidance. We really do appreciate that we want to evolve our working day, and as dental therapists and as dental hygienists, we want to make sure that we stay within our boundaries, within our training and within our scope. If you have a question for a future episode of Dental Health Matters, do get in touch at bsdht.org.uk/podcast.
That brings us to the end of today's episode of Dental Health Matters. Thank you so much for listening. I hope you found today's conversation helpful and informative. If you enjoyed this episode, please remember to subscribe, leave a review, or share it with someone who you know might benefit. See you next time.